Well, welcome everyone to our second plenary of the day. My name is Mark Gilbert, and I work at the BC Centre for Disease Control. And I have the pleasure of doing work with folks who are working in the area of online sexual health services and digital health. And so it's a real pleasure for me today to be introducing Patrick Sullivan, who's going to be telling us more about this and his work that he's involved in. So I'll tell you a little bit about Patrick. So Patrick is the Charles Howard Candler Professor of Epidemiology at Emory University's Rollins School of Public Health, the co-director of the Prevention Sciences Core at Emory's Center for AIDS Research, and a past member of the U.S. Presidential Advisory Council on HIV/AIDS. He served at the U.S. Centers for Disease Control, or the CDC, from 1994 to 2008. His career has included work on HIV surveillance at the U.S. Centers for Disease Control and Prevention, HIV vaccine research at the National Institutes of Health-supported HIV Vaccine Trials Network, and research on technology-enabled HIV prevention for MSM supported by the U.S. NIH and CDC. And while we have great weather here today, Patrick is going to be heading off tomorrow to go to southern Florida to visit with his son who's in college there for some mid-semester and some good summer weather. So welcome, and we're glad you can be here with us today before you take off for sunnier climes, Patrick.
Good morning, and thanks so much for the opportunity to be here. I've been in the sessions and in the break areas and chatting with people, and I think this is a really remarkable model for having dialogue between folks who are working in clinical and research areas and folks in the community, and one that I hope I can be inspired by and bring back to the U.S. So thanks for this opportunity. Today I'm going to talk about digital approaches to HIV prevention, and I think my background started with work in public health surveillance, so I always sort of come back to informing what we do by where the needs are greatest. So in the US, we've actually, over the last decade or so, been experiencing a slow decline in the number of new diagnoses from year to year in gay and bisexual men, about a 5% decrease over this period. But as often happens in the epidemics that we're worried about, even those small gains haven't been shared equitably. So although declines have been relatively high in white gay and bisexual men, there have been no decrease to a small increase in black men who have sex with men, a 16% increase in Hispanic Latino MSM. And these differences also are inequitably distributed by age. So that same 5% decrease overall in the US in the last decade in new diagnoses translates into almost a 10% decrease in young gay and bisexual men ages 13 to 24, and over about a 28% increase in those ages 25 to 34. So we need to be thinking about prevention methods that are really going to reach the populations who are not benefiting from the improvements in the epidemic that we're seeing in the US. One of my colleagues, Johanna Chapin-Bardalis, worked with 13 high-income countries that have similar case-based surveillance systems to identify country-specific trends in new diagnoses in men who have sex with men. And I just want to highlight this figure from her paper that although the countries had different trends across this period of years, the one thing that was common to all the countries is that in every country that was in this group, the proportion of new diagnoses in young men who have sex, or in men who have sex with men that were in that youngest age group, the 15 to 24-year-olds, increased. So in the US, we had the distinction of having the highest proportion of new diagnoses among these youngest MSM. The data from Canada are in the pink, the filled pink triangles that you can see. There's also a substantial increase in Canadian young gay and bisexual men. At the same time in the US, we have increasing rates of sexually transmitted diseases, and so for an infection like gonorrhea, which has been low and relatively stable in men who have sex with women and in women, we've seen recent increases in men who have sex with men, in primary and secondary syphilis. Most cases reported are in men who have sex with men with an increasing trend. And so I show you all this just to say that when we think about digital interventions, I really grew up up scientifically working on HIV prevention, but I think the evidence is clear that not just from a point of view of people's broader sexual health, but also from the point of view of epidemic synergy, that we need to be thinking more broadly about where we engage. And so why digital interventions? By digital interventions, I think about interventions that take advantage of things like computers, mobile phones, website games, social media, internet, and what do digital interventions do for us in prevention? So digital interventions can help us reach a broad scale of people with services. We can reach clients who are remote. There was some great discussion this morning about the epidemic in more rural parts or less sparsely populated parts of Canada. We have the same issue. Digital interventions can provide rich media like videos to communicate information. We can provide tailoring of interventions, reminders of routine prevention services, engagement through chat or through video chat, and finally linking interventions together. So if you are getting information about a sexually transmitted infection and order a test kit and get a diagnosis, we need to link that to a discussion of PrEP immediately. And so digital interventions let us link those, make those logical links. So I'm going to show you examples of all of these by talking about some of the projects that we're working on. I mentioned before that we need to be sure that digital interventions reach the populations who need them most. And historically, in the US, we worried about both that the price points of smartphones could be exclusionary for some younger people. There was a time not that long ago when we started our kids out on flip phones, if you remember flip phones. But that time has passed, and according to these data from the Pew Research Center, a very high proportion of US adults have access to cell phones. That's been increasing, but that lower line in green shows that in the last 6 to 7 years that there's been an even steeper growth in the proportion of those that are smartphones. We also worried about the so-called digital divide, which is, do communities of color have equal access to high-speed data? And that's also, that gap's really closed. So by February of 2018, the highest proportion of smartphone ownership was actually among young Americans aged 18 to 29, and Black and Hispanic Americans were equally likely to have smartphones. So some of that digital divide has narrowed, and so we feel like we can really reach the populations who are at most need in addressing the health of LGBT people. And finally, I want to say that in the US, a feature of government is that maybe I'll just say our government, because others are likely better, is that the things tend to get siloed. And so HIV prevention resources and discussions can happen in a box that's separate from STI prevention resources and discussions. But these HIV and STI prevention are really stronger together. These are data from 3 recent publications that ask the question about the population attributable fraction of HIV that is attributable to rectal gonorrhea and chlamydia for gay and bisexual men. And really the practical, what this population attributable fraction means is that this is a fraction of HIV infections that only occur because of asymptomatic rectal STIs. In prevention terms, if we got rid of asymptomatic rectal STIs, we could eliminate this proportion of new HIV infections. And these different methods range from 10 to 15% of new HIV infections just by addressing asymptomatic rectal STIs. In the US, that would translate to averting about 3,000 to 4,000 HIV infections per year, with potential lifetime cost savings of 1.5, I believe that's trillion, my 10 to the 9th and 10 to the 8th there, 1.5 trillion. So there's a lot of opportunity just in doing a better job with STI screening. So how much intervention do we need? How much is enough? We've looked at this closely with PrEP, where in a series of countries and with 3 different modelers, we've asked the question, how much PrEP coverage do you need, which is on the horizontal axis, to get a certain reduction in new infections among a population of gay and bisexual men? And so these different dots represent different models, but these are from the US, Peru, Kenya, India, and South Africa. And you can see the sort of line that they lay out. And as you expect, the more PrEP coverage you get, the more infections you can avert. The other point is that it's not perfectly translatable. So even if you get, for example, 40% coverage of PrEP, that probably translates to something between a 20 and 25% reduction in new HIV infections, because some people start and stop PrEP, because PrEP is imperfectly efficacious. But this suggests we should be aiming for 30 to 50% coverage of PrEP in the men for whom it's indicated. I also want to show you a little bit more data from this modeling in South Africa that was led by Ron Brookmeyer. And what Ron did was asked about how many infections we could avert with PrEP, 25% coverage of PrEP, which is the far left blue bar. But then in the orange bar next to it said, what if we also doubled HIV testing, so more men had an opportunity to be tested and enter PrEP care? And there's a meaningful increase just by improving testing in the context of a PrEP program. What if we also increase condom use by 25%? That's the plus PrEP, that's the blue bar in the middle. What if we also increase testing above that? What if we put PrEP and condoms together? And what if we increase testing beyond that? So the point is that putting these interventions together, as you would expect, really builds more prevention value than just focusing on something like PrEP. So in the US, to make modest impacts on HIV transmissions and MSM, we're going to need to achieve 30 to 50% coverage of multiple interventions. And how are we doing with that? These are data from our American Men's Internet Survey, which is very much along the lines of the Sex Now program that you have in Canada, all internet-based, about 10,000 men per year. My colleague Travis Sanchez has been collecting these data, and here we look at the trends in awareness, willingness, and use for PrEP. So the top line being awareness from 2013 to 2017, and the left panel non-Hispanic white MSM. So you can see that we've had increases in awareness of PrEP, that we've had increases in willingness to use PrEP in the red line, but by 2017, we just barely got to about 20% ever having used PrEP. And that was roughly the same in our white non-Hispanic MSM and other MSM. In terms of STI testing from the AMOS data, these are stratified into 4 groups. So the first 2 groups are for people living with HIV. About 70% reported an HIV test in the past year. And of those, a little more than a third had a positive result. In the HIV negative men, 40% had tested for STIs, and about 9% had a positive result. The use of these services is challenging in rural areas of the US, and I think this is common in a lot of countries. So these just show paired bars, blue for rural, green for urban, of a number of prevention services, and these are the prevalence ratios for those. So men in rural and urban areas in the far left had an equal likelihood of having unprotected anal sex. But in the next set of bars, the rural men were less likely to have had an HIV test in the last 12 months, less likely to have received condoms, to have received an individual level intervention, to have received a gonorrhea or a syphilis test. So this is an important feature of digital health tools, is that we can get more reach to rural areas. So how can digital interventions help? Specifically, we think digital interventions to increase the use of sexual health interventions can increase understanding of recommended services. We had a long process as we started to develop these tools of engagement with community. Many of us doing the research are gay, bi, or trans folk ourselves. And so one of the things that was really clear was gay men are tired of being told, because you're a gay man, you need to get an HIV test, you need to use condoms, you need to do this, you need to do that. People want to get feedback that's really based on what their experience is, on what their patterns of having sex are, and that are meaningfully tailored to them. We want to increase motivation to use services, and I'll talk about the behavioral theory we use to do that. Navigating people to service locations that are closest to their house, and if there's not one close, allowing a mail-out option. Reminding them to utilize services they have planned. So if I've made a plan to test for HIV every 3 months, I can choose to be reminded of that. Tailoring services to increase their relevance. Meaning, again, when you get a general recommendation that says gay men should do this, it's more impactful if you have talked to a provider or if you've screened yourself and said, because you told me that you have this pattern or this frequency of sex, we recommend that you be screened with this frequency for STIs. And finally, providing the opportunity for mail-out kits. So let's start with HealthMinder, which is a mobile app that we've been working on in different iterations for 7 or 8 years. We started this process by meeting with a large number of stakeholders: community-based organizations, prevention providers, government, philanthropic funders, to ask what people wanted in an app. And we have a couple papers out, and one of them is called Developing a Sexual Health App, a Community-Driven Process, that talks about how input from all these stakeholders resulted in the app that we have. And the premise here is pretty straightforward, which is on the left side, the data feature one is protect my data, so people can't open the app and see what I've been doing and planning on doing. And then the first thing men do is answer a series of questions, and the feedback that we give is based on what we heard from community, and each thing that we recommend says, because you said that you're unhappy with the condoms you use, we recommend that you order this pack of condoms that includes a lot of different types you might not have tried. Click here and you can order those, have them sent to your home. Because you said that you haven't been tested for HIV in the last 12 months, we recommend that you schedule a test now. There's another feature that helps men to decide how often they want to rescreen for HIV and set up a schedule for that and decide how they want to be reminded. In the middle is some information that would walk men through choosing a plan for HIV testing. On the right is an ordering panel where men can order at-home HIV tests, condoms, lube, and in some iterations of this STI test. I should also say that there's screeners for PrEP eligibility. One of the things we know about PrEP is that men have seasons of risk. And so I may not be a PrEP candidate today, but a month from now I might be. And so we want to sort of get past the idea like, yeah, I talked to my doctor about PrEP and she said I don't need that. So again, men have the option once a month of just being suggested, like, let's check in and see if you might be a PrEP candidate now. Screening for post-exposure prophylaxis, I've had an exposure, should I be going to an emergency room? Those questions can be answered, and men are either directed to go to an emergency room, shown the closest one that's open, or referred for follow-up evaluation. So this is based on social cognitive theory, which can shape a lot of different health behaviors. So in the yellow box here in HealthMinder, for prevention, we would be thinking about trying to get men to test for HIV regularly, to do regular PrEP assessments, regular NPEP assessments, consistent correct condom use, and adherence to PrEP and NPEP. For men who are living with HIV, retention and care, adherence to ART. So I've given an example for HIV testing with the 4 domains of social cognitive theory, but we would say men who use the app to plan and manage their HIV testing would say the following kinds of things. 1, they've set goals. I've chosen a plan to test regularly for HIV that works for me. 2 is self-efficacy. I can make and achieve that plan to test for HIV regularly because I get reminders, because I can order a test if it's not convenient for me to go out. 3rd is outcome expectations. If I adhere to that plan to test myself for regularly for HIV, I'm going to stay healthier and I'm going to protect my partners. And 4th is self-regulation. I can see that I've stuck with my plan. As you go through and test regularly, you sort of get checked off, and that is really, you have that in all kinds of apps, but it's really a behavioral modification component. So we tested this app, the first version of it, with a series of men in Atlanta and Seattle. We enrolled 121 of them who had never tested positive and just gave them the app and asked them to use it for 4 months. 98 of those completed a final evaluation. These are the resources that men used when they were given the chance to use the app. Again, they weren't incentivized to do anything in particular. It's sort of like, use this app as you would use it. Almost all of them at the first visit did an initial assessment, this initial questions that give you recommendations. But many of them came back over a 4-month period and said they wanted to update their assessment and see what else might be recommended to them. So nearly half did at least 2 assessments in that 4-month period. Over half looked for HIV testing locations. Over 70% made a plan to test regularly for HIV on a certain interval. On the orange bars, 40% sought out additional PrEP information and screened themselves, and about a third screened themselves for PrEP multiple times. So just on the testing front, at baseline, we asked men if they had a plan to test regularly for HIV. About half of them did. For the half that didn't, by the end of the study, 2/3 of them had developed a plan to test regularly for HIV. So by the end, I think it was 86% of all the men had a plan to test regularly for HIV. In other evaluation results, one of the things we did in the beginning was ask men if they were using condoms, and if so, we asked, do you like the condoms you're using? It might shock you to find that most men do not like the condoms they're using. A very high proportion said no, they didn't like them. So our statement was, because you said you don't like the condoms you used, we think you should try out a bigger assortment. Let us mail those to you. So 78% of those who reported being dissatisfied with their current condoms ordered new ones, and 87% of those said that they used those condoms that we mailed them. About over half of men ordered an at-home HIV test kit. 2/3 of them, when we screened them at the beginning, we asked, are you planning to test for HIV in the next 4 months? And of all the ones who ordered, 2/3 of them had said, no, I'm not planning to test for HIV in the next 4 months, but when offered a kit, decided to order one. By the end of the study, 83% of all the men had a plan for regular testing, and 9% of the PrEP-eligible men started PrEP in that 4-month period. We also did qualitative interviews with men who had either started PrEP, not started PrEP, or used different components. This is a quote from one of the men who started PrEP while on the app, and he said, I went through and put in my screener responses, and it said, hey, you should check out PrEP. And by the way, here are some places you could go. I was seen for PrEP at that provider within a week, easy breezy. HealthMinder was the piece that crossed the threshold from inaction to action. This will save lives, and I can say maybe even mine. For folks who do behavioral research, this idea of the threshold to action is really meaningful. So this is what this participant came out with, but aligns really well with what we try and do with behavior change interventions, which is to help people make that transition. So this app is now being tested or been tested in 4 different RCTs. We just completed data collection on the left for M-Cubed, which was taking this app and adding a little more prevention and video messages for 8 men who were living with HIV, high-risk HIV-negative men and lower-risk HIV-negative men. So that RCT is done, and we expect results out next year. We're just starting an app that has enhanced PrEP content and PrEP navigation that will happen in 3 southern U.S. cities starting is it November now, this month. Know at Home is a comparative effectiveness study of mailing out HIV test kits and supporting them with the HealthMinder app. And then the last one on the end, My Choices, is the app adapted for adolescents that's particularly being used with men as young as 15. And so it's more developmentally appropriate language with a lot of input from adolescent potential users. And in all these, we've added an STI to the offering so that there's comprehensive services. So I want to talk a bit about eStamp. This is a study of mail-out HIV test kits. And this is, I think, a hot topic. In the coming couple weeks, the results of this study will be released in full. And there's sort of a bit more hopeful information about prevention, but I want to tell you about it and about some of the process measures. So this was a CDC Emory study where basically we mailed out test kits to gay and bisexual men in the United States. The eligibility was men who were not known to be living with HIV, and the intervention arm participants got mailed 4 HIV rapid tests at once. And part of our purpose was that we wanted men to be free to use those tests, but also to give them to people that they wanted to give them to, whoever that would be. We had a 12-month follow-up, and one of the important outcomes was the number of HIV tests men took in a year. So this was the idea. We screened nearly 11,000 men. We recruited them all through social media. We registered 3,800, and 2,600 completed the baseline. We split them into an intervention arm where we mailed them 4 rapid tests. And then every 3 months, we asked them to do a survey, and if they had either used those kits or given them away, they could order 4 more. So they could order up to 16 kits during the year. And then we got follow-up data from them at 3, 6, 9, and 12 months. So this is a high-level view, these data are oriented by some of the behaviors reported, and then there's an intervention arm. These are guys who were mailed kits, the control arm, guys who were not. So in the top line, of the men who were mailed an HIV test kit, only 3% of them didn't test for HIV in the year. And that was about 36% in the control men who were given the surveys but not mailed out kits. About 80% of the men mailed kits tested for HIV at least 3 times in the year, compared to less than a quarter of the men who were not mailed kits. The mean number of tests in the intervention arm was 5.5 compared to 1.5 in the control arm. There was a decrease in facility-based testing among the men we mailed kits to. They were less likely to get tested in a community-based organization or at a medical provider, and the control men were a little more likely to. I can tell you that another common question is, can we link these men to care after they report a positive test result? and the linkage to care among the group of men who tested positive at home, the linkage to care within 30 days was about 3/4, which was statistically the same as the linkage to care in men in the control arm who tested in a provider's office. And we do that through actively reaching out to men who report a positive test and helping them navigate into care. At-home STI testing, we've really built on the model of these HIV self-tests, and we've developed and supported the use of STI collection kits. So we mail these kits out with instructions as well as a video. We collect urine, rectal swab, pharyngeal swab, and finger stick blood, and we can do the tests that you see indicated here. We've pretty much added this into almost everything we do online, the offering of at-home STI kits, and for a couple reasons. One, I mentioned before the epidemiologic importance of asymptomatic rectal gonorrhea and chlamydia infections. And in the US and in the South, there is still a gap in, I would say, provider competency to offer and to be comfortable offering rectal STI screening. So this is a service that men really want and may just struggle to get in their care kit settings. In the M-Cube study, which I mentioned, we offered, men used the app for 3 months, and we offered them HIV STI kits, condoms, and lube. And so you can see about half of the men ordered HIV test kits, about 40% STI kits, and about the same for condoms and lubricant to be shipped to their homes. These mail-out STI kits have also been acceptable among younger MSM, and I want to highlight here intervention that was developed by Brian Mustansky that we at Emory were one of the 3 sites who tested this. This is an e-health intervention that's targeted at young MSM who've just had a negative test result. And Brian and his group have done great work of interviewing men who've just gotten a negative HIV test result and asked them what they thought that meant. And some of the common answers were, I'm lucky, or I'm doing things right because I didn't have a positive test result today. So Keep It Up was meant to follow on a negative test result to say, you're doing great, and now you got to keep it up. And it's a series of 6 online delivered modules. Some are videos, some are interactive exercises that are more related to prevention knowledge. And this was evaluated in a multi-city sample of 901 young men who have sex with men. These are the STI outcomes from that study. So 7 sessions plus 2 boosters, all delivered by web app, and the outcome was STI prevalence at 12 months. So what this shows, the risk ratios over on the right show the reduction in STIs among the men who got the intervention. And the very bottom line, any STI, there's over a 40% reduction in acquiring sexually transmitted infections among these young MSM. So one, a successful, completely digitally delivered prevention intervention. But the other notable thing is that of these at-home specimen collection kits, 1,113 were distributed, and these are to adolescent and young men who have sex with men. 89% of them return specimens. So although we initially wondered, are men going to be willing to collect these specimens at home and comfortable with proper instructions, men are able and willing to do this and return specimens. This has led to a program called Prep at Home, and the problem that we're trying to address here is that when men go on PrEP, part of the monitoring for that is coming back to the doctor every 3 months. A lot of the men we want to reach are young MSM. Young men, in the US at least, are historically epically bad at going to the doctor. And so the idea of going to the doctor every 3 months in order to maintain a PrEP prescription could be a challenge. The other thing is that if we got that 30 to 50% of MSM on PrEP that we think we need to in the US, that would result in millions of more provider visits. And we have a healthcare system in which there are often long waits to get an appointment. And do we want to add 3 or 4 or 5 million more provider visits for this purpose? So our concept was a home care kit that could let men do their follow-up PrEP visits from home. And I want to acknowledge that this work, the first work here funded by NIH in R21, and my colleague Aaron Siegler at Emory worked on this first phase and is leading now a second phase of doing an RCT of this. You can see the kit on the left. My thought was that this should be like getting an iPhone where the box is so tight, you know, that you have to like pry to get it apart. that everything had its place, or like a bento box. So we made these kits, which turned out to be prohibitively expensive to produce. And so they now are less fancy, less colorful, and more affordable. We tested this home support system by finding men who were on PrEP and asking them to complete the PrEP at home process and then to give us feedback about it. Basically what we do is we mail out a kit. They do a survey to ask about their adherence, their condom use, other side effects, other concerns they have, and then they mail in these specimens that does all the testing. We have a video online that illustrates this process. We thought it was humorous. It's probably not really humorous, but it's lighthearted and illustrates the steps. And then we asked both their PrEP providers and men who'd used the kit. And here's some of what we heard. The provider said, anything that's going to help me do PrEP well to be able to provide these services, I think it's fantastic. Another provider said, I think we need to decentralize for folks who don't have good experience or access to providers. So another important point here is that some folks we would like to be on PrEP have historically not been treated well or respectfully in clinics. And so decentralizing that makes sense, especially for young, healthy folks. From one of the PrEP users who used it, I think it's useful, especially for the STI testing. 22 out of 55 patients said they were more likely to remain on PrEP if they could do their visits by this mail-in system. And 48 out of 55 said, if you offered me the choice for my next 3-month visit of mailing in specimens or going in, I would use the at-home kit. And so based on those preliminary data, NIH is supporting a randomized trial in 3 US cities where men are randomized to either be told to go back into their doctor for their 3-month visits or mailed out these kits. And one of the outcomes is persistence on PrEP, men's willingness to stay on PrEP if they don't have to make these extra visits, and that's being led by Aaron Siegler. Last, I'm going to show you a few more examples to cover. I talked about some of those things that digital interventions can do, and I want to show you some specific examples of research products that are in process that address those different areas. So what I'm showing you here is all the rows here are studies that are being tested, apps that are being tested in the Adolescent Trials Network of the US. So this is a research network that focuses on interventions for 13 to 24-year-olds. And each of these lines, I'll show you several of them, are generally app or web-based interventions. And then the colored bars here show the span of the care continuum we're reaching through these digital interventions. So the orange is entry into care or engagement. The blue is the PrEP continuum. The yellow is the treatment continuum. The red are psychosocial and barriers and risk behaviors. So addressing things like social support. And then the last set are structural variables, including navigating stigma, other things that may discourage people from getting services. So many of these interventions are just trying different behavioral theories, different ways of presenting information and services to try and go across the continuum. And you'll notice that many of them are serostatus neutral so that they cross over into serving young people who are living with HIV or not. So first I want to mention Get Connected as an example of tailoring. This is led by Jose Bauermeister and Rob Stevenson. And Get Connected is about HIV testing. It's a brief online intervention, but we tailor at 2 levels here. So the first is we send out secret shoppers in the cities who are youth who would need HIV testing services, and they go to community testing providers and get an HIV test. And then they rate some things about where they offered STI testing, was appropriate language used, were pronouns respected, did they get their questions answered? And that helps us define a universe of places with specific attributes. By the way, we tell the community-based organizations in advance that we're going to be doing mystery shopping, and we offer to give them feedback when mystery shoppers have attended their services. When men use the app, the tailoring is in a couple ways. First is, I may say, I'm somebody who wants to be tested, but I want to go to a place that is gay-friendly. Or I want to go to a place that is not explicitly gay-serving. And so I should be able to make that choice. And now we have the data from secret shopping to inform that. It also may be that my priority is someplace that's walking distance from a bus stop or open on the weekends. So that's one level of tailoring. The other level is values, and so the introductory survey asks about what's most important to you. Is it being healthy? Is it being sexy? Is it being confident? And then the messaging is actually tailored to those values. So if we're talking about getting an HIV test and your primary value is being sexy, the message might be nothing says sexy like being confident, and nothing helps you be confident like knowing your HIV status. Get tested. If it's being healthy, like a great way to protect your health and that of your partners is to get an HIV test. So we're presenting the same recommendation. All of these young men who are sexually active need to have this service, but we're framing it in terms of their own values. So this is now nearly done enrolling. In Atlanta, we've enrolled 112 of our quota of 120. It's being done in multiple cities, so you should expect results in the next year or so. Next, tailoring and reminders. So this is a version of the HealthMinder app called My Choices. But here, one of the things they've added in is actually a geolocation service, so that they've used geofencing to define HIV testing areas so that young people can get a reminder when they're close to a service. And this addresses an adolescent, a characteristic of adolescence. And I said, like, I have one myself now, a young adult man who, and often the planning process develops a little bit slower in adolescent young men. And so getting that reminder when you're close to the thing that you need to do, I use that on my own phone for all kinds of things. And so, but it uses geofencing. So with men's consent, they can be reminded when they're close to a service they need. This is led by Katie Biello and Ken Mayer at Fenway. Delivering rich media. So the M-Cubed app that I mentioned, we had previously provided information, but here are offering information, some in message format and some in video format. So the fact this is Patrick's story, this just happens to be the video that we used was from a guy named Patrick. But we push out this information, some as infographics and text, some as videos. And in this research process, we're actually asking users to rate those messages. So on the left is a video one, on the right is a text-based one, and we're able to look at which kinds of users prefer which type of information, and then track also for those who got a video message, did they have what kind of rates did they have of going on to access a certain service. And then broad reach, I'll mention ePrep. I think this really speaks to that gap in services for people in rural areas in the US, and so again, Aaron Siegler is leading this effort where Prep at Home is doing the follow-up visits by mail. ePrep is, Aaron calls it prep delivered to your couch. And so the first interaction would be screening for PrEP eligibility, and then men can set up a video consultation to discuss with a provider, get a mail-out kit for their baseline labs, initiate PrEP with either a mailed paper prescription or an electronic prescription, and then all of the follow-up visits can be done through that Prep at Home system. So this is currently being tested in 3 southern states, focusing in rural areas. So in conclusion, in the US, young MSM are especially heavily impacted by HIV and STIs, and I think digital interventions are a unique opportunity to promote the use of basic prevention services like HIV and STI testing, but also increasingly important clinical services and biomedical prevention like PrEP. Mail-out HIV and STI testing is highly acceptable, and this is allowing us to do more digital interventions that include a biological testing component. And the biology here is really important. The behavior change is important, but the biology is very important, and especially addressing these undiagnosed rectal STIs. STI outcomes are also excellent outcomes for sexual health interventions. And in fact, in Brian Mustansky's Keep It Up intervention, if we had only looked at HIV infections as an outcome, we would have called that an unsuccessful intervention. But the fact that STI infections are a more sensitive indicator of risk makes them a great sort of outcome for trials. The idea that tailoring may help make interventions more personal and impactful, and this isn't just theory, this is the thing we heard from the first time we interacted with men to whom we were trying to provide services, was don't wag your finger at me and say, because you're a gay man, I need you to do A, B, and C. And so the idea that there is more of an interaction and that the apps and the providers are interested in what your circumstances are and in giving you choices is an important way to help users be bought in. And finally, there's a big pipeline of digital interventions that are being developed and evaluated. Some of these you're going to be hearing about, I would say, in the next 6 months. Some of these you're going to be hearing about in the next year or two. And then there's a really rich opportunity to adapt those, for example, to rural users, to younger users, to some racial ethnic communities that are less served. And so that's sort of a next phase of taking these tools and adaptation. So I want to thank, I'm representing the work here that's supported by a lot of folks and with a lot of great collaborators. I really appreciate the opportunity to be here today, and I think we may have just a couple minutes for questions. Thank you.
Thanks, Patrick. Thanks, Patrick, for a great presentation. We do have time for maybe one question, and I see some, well, 2 questions. Here we go. Great. Over on the left.
Hi.
Thanks for coming today. This was a great presentation. I actually used to work at a Ryan White clinic in Atlanta as well as the Hope Clinic doing some vaccine research trials, so very interesting to hear this. I wonder if you have any information or if there was some thought around kind of decreasing inequities in access for men of color. So is there anything in, like, for example, I guess evaluation of the use of the various apps or testing products and or kind of components of the app that would direct folks who had low or poor access to healthcare, so directing them to the specific services for folks who didn't have insurance, that type of thing?
Yeah, that's a great question. So we're in the process of, one of the first components for that was actually developing a national resource in the U.S. of PrEP providers and their characteristics. For example, those that provide no-cost services or those that accept Medicaid. And so we now have that database and are integrating that as part of a faceted search if there are particular requirements around, for example, free services. So I think that's another piece of tailoring that's really important, and I'd say we're getting there in the same way that we tailor in other factors. Thanks.
Daryl?
Hi, Daryl Tan. I'm an ID doc and a researcher in Toronto. Fantastic presentation. A lot of what you said really resonates with a lot of what myself and others are trying to implement here in Canada. So congratulations on all that work. I wonder if I can ask 2 quick questions. The first is a bit of an informational question about the PrEP at home thing, and the second one is a bit more reflective. So with the PrEP at home project, it makes perfect sense, something we're also very interested in trying to implement because we shouldn't have people coming in all the time indefinitely while they're on PrEP. If we can avoid it. I wonder whether you've had any pushback from potentially providers who might not be salaried in that the extra bit of, in some health systems, the way that physicians or any clinician is compensated is dependent on because of the structure of the health system, the way that it's set up is that people have to come in, they have to have an encounter in order to get paid, right? And as we try to ramp up PrEP, obviously that means a lot more work potentially. And is there any pushback that you've encountered in people saying, well, you're asking me to do this extra work now on an online app that I'm not going to be compensated for? How do we reconcile that? The second question is a bit more reflective. So you presented a whole bunch of amazing sounding e-interventions, and there's many else, others that are out there that are really exciting and promising. These, development of these apps is really expensive. IT is expensive. It's complicated to make it flashy and attractive and user-friendly and all that. And I just wondered to what extent you feel like, knowing the field, is there a risk of an overly crowded marketplace? Is there too much boutique-y kind of stuff happening here and there and everywhere? And are we reproducing the wheel too many times and wasting resources potentially as a result? How do we democratize that process?
2 great questions. In our work, we have not had pushback, and I think this may relate somewhat to just how overcrowded our healthcare providers feel, and maybe that some of our systems of reimbursement for providers are less linked to the number of visits. I think what we've been naive about living in a research world is that we haven't yet tackled what this would look like in a regulatory sense, because the telemedicine requirements are different in different states. We have more of a leeway within a research setting, and just the reimbursement for those services. So I think you raise important questions. We just haven't hit them yet. And then the other question that you raised is about the cost of this and are we going to get too crowded? I'm so glad you asked that question because it's something I think a lot about. And I just want to say that the first, you saw all that's cascaded out of our HealthMinder app. That HealthMinder app was supported by the MacAIDS Fund. It was philanthropic entrepreneurship, that they invested in building something because we promised that if we built it, one is that NIH doesn't, it's harder to get government investment to do all this work with community. I think the goal of government investment, some government investment, is like to get to the product. So MacAIDS Fund both allowed us to engage richly with community, but also we promised that we would make this available to people who wanted to build on it, because HIV testing, STI testing, how many times do we need to program a PrEP screener or a PEP screener? So there are more versions of this that we're not testing that we've made available, a version that's focusing in Latinx communities. We've made a version available that's being adapted to use in women. And I would say if there's anybody here who wants to build on this, we've just sort of said the developer can use that code, you can just make modifications to it. I do think that we have a responsibility to develop tools that can be shared resources. So I'm glad you asked that as a way to say, we're happy to be transparent, to share a version with people and to let people essentially pay to develop that last mile for the population they're trying to serve. And that's why you see Fenway and like all these different branches off this tree is, I think, and I would encourage anybody who's developing these tools to just find ways and be transparent. In our experience, I feel like we have lost nothing by sharing this with everybody who wants it. We have gained a great deal by learning from their experiences. So it's a great question.
So just thank you, Patrick, for the presentation today. Just for something on behalf of the summit organizers.
Thank you very much.
And I think Patrick's around today, so if you have other questions, come and find him.
Thank you so much, Mark, and thank you so much, Patrick, for that amazing presentation. So just a quick reminder, we have a table set up just outside of the doors in Ballroom A for headsets if you need them for the afternoon sessions that will be delivered in French. So I just encourage you to please try and sign yours out sooner rather than later. Please don't wait till the last 5 minutes, just so that we can make sure that we get started right on time at 1 p.m. So thanks, and I hope you all enjoy lunch.
Thank you.